Hello friends, I am Dr. Gunjan Chanchlani from Mumbai, and I want to thank Academy for Clinical Education and Dr. Pankaj Anand for giving me this opportunity. So my topic for the workshop is mechanical ventilation in a patient with COPD, asthma and congestive heart failure. So mechanical ventilation in COPD of asthma, that is an obstructive airway disease, is actually a favorite topic of mine. The reason being that it's a very tricky topic to understand, and it's more trickier to make somebody else understand. So let's begin. So my agenda for today is to first understand what do we mean by obstructive airway disease and what is the pathophysiology on it. Then we will discuss on what ventilator settings should we set so that we can successfully ventilate these patients, and also how should we wean these patients or successfully wean these patients. I will also be in short talking about how to ventilate a patient of congestive heart failure. So there won't be much to talk about it once we talk of obstructive airway disease. And we will not be covering any medical management of either the obstructive airway disease or congestive heart failure. We will just be talking or sticking to our topic, that is just mechanical ventilation in these two diseases. So what do we really mean by obstructive airway disease? So there are two types of airway diseases. Basically, there's obstructive airway disease and restrictive airway disease. So asthma is a type of obstructive airway disease where there is acute severe obstruction, which limits mainly the expiratory airflow. COPD is a similar phenomena, but is chronic in nature, where obstruction is kind of permanent or irreversible to bronchodilators, and with acute exacerbations or increase in obstruction intermittently. But in some asthmatic who have been having prolonged disease or who are not compliant with their medications, they may have chronic changes in their airways in the form of thickening of the bronchial mucosa or kind of partial reversibility with bronchodilators, and they may kind of give partial reversibility with bronchodilators. And so now the terminology, instead of obstructive airway disease or COPD and asthma, it's now called as asthma and COPD overlap syndrome. So what is the pathophysiology of obstructive airway disease? So is it increased resistance? Is it loss of elastic recoil? Is it airway collapse or increased compliance? So the pathophysiology in obstructive airway disease is quite complicated, and it includes all the four things that are listed here. That means here the correct option is all of the above. So let's slowly go and see how the pathophysiology works. So here we are seeing the cut section of two airways. The above airway is the normal bronchus in a normal patient, and the airway, the cross section down is a patient who died of acute severe asthma. And here you can see that there is a thickness in the bronchial wall. There is inflammation with number of inflammatory cells. There is bronchoconstriction and bronchial obstruction due to secretions and mucosal edema. And it is easy to imagine that these abnormalities at the bronchus level increase the airway resistance, not only during expiration, but also during inspiration. And this expiratory airway obstruction, which is of significance to us when we ventilate these patients. Next terminology before we start is what we need to understand what is PEEP. PEEP is the pressure in the alveoli at the end of complete exhalation or at the end of exhalation, which is greater than the atmospheric pressure. Okay, so a PEEP, the purpose of PEEP is to keep the alveoli open. Next important terminology here would be what is a time constant. So here, as you can see, a time constant, there are two graphs. One is of a normal patient and one is of a COPD patient. So when we talk of the terminology time constant, it means the capacity of the alveoli to exhale or exhale the tidal volume that was inhaled during this breath. That or the time duration required for the same is known as time constant. So a time constant is different for each alveoli in our lungs. So our lungs have millions of alveoli inside us. So all these alveoli have their different time constants, with some obviously synchronizing with the other, but they have different time constants. And by experimental studies, it has been shown that in one time constant, there is 63% of the alveoli which are emptied. Okay, and it requires three time constants to completely exhale the tidal volume that was inhaled. Okay, so in a normal lung, which has a compliance of 0.1 and a resistance of 5, the time constant is 0.5 seconds. Okay, so the time constant is a product of compliance into resistance. Okay, so to completely exhale the tidal volume that was inhaled, this lung, a normal lung, would require 3 time constants. That is, it would require 1.5 seconds. But if you see in the COPD lung, in the COPD lung, because of the obstruction that is there during expiration, the time constant of the alveoli changes. So the time constant, because of the increase in the resistance and the increase in the compliance that happens because of COPD, because of the obstruction, there is the time constant now is 3 seconds. So that means to completely empty this lung of COPD patient, it will take us 3 time constants. That is, it would take us 9 seconds to completely exhale the tidal volume that was inhaled in this breath. And if you can see in the 0.5 seconds, that is the time constant which was for the normal lung, this COPD lung could hardly expire less than 20% of the tidal volume that was inhaled. Now this time constant happens mainly because of 2 reasons. One reason is there is airway narrowing, and because of the pathophysiology of the COPD and asthma, this airway narrowing causes obstruction to the air during expiration. At the same time, because of over distension or the air trapping that happens because of incomplete exhalation, increases the compliance of these lungs or causes distension of the alveoli, increasing its compliance and loss of elasticity. This further worsens the time constant. Okay, so a COPD lung would have a double issue. That is, it has a problem not just because of narrowing of the airway, but also because of loss of elasticity in the alveoli. Having understood what is time constant, let us now understand another terminology, which is dynamic pulmonary hyperinflation. So the final product of these changes that have happened, that because of COPD or in obstructive airway disease, will result in dynamic pulmonary hyperinflation. So what happens is, as you can see in the lower graph, there is inhalation and there is complete exhalation. Inhalation and complete exhalation with every breath. But in a COPD or an obstructive or a asthmatic lung, there is incomplete expiration and therefore there is air trapping. So there is inhalation and incomplete expiration. So there, the end expiratory lung volume is more than what a normal lung would have. Now in the second breath, there is again a similar inhalation, or the same tidal volume which was inhaled in the previous breath is inhaled again. And now the end inspiratory lung volume is also higher than what it was in the previous breath. So eventually, with progressive increase in time, not only does the end expiratory lung volume increase, but also eventually there is increase in the end inspiratory lung volume when we add the tidal volume to the functional residual capacity after each breath cycle. This is what is dynamic pulmonary hyperinflation. So what do we mean by the term dynamic? Dynamic has nothing to do with spontaneous breathing. Dynamic is a question of time. Here again, there are 2 kinds of time. That is, when we talk of time, one is the dynamic, that as the time passes, there is worsening in the dynamic hyperinflation, and other time is the time constant that we talked of. And because of this time constant that is there, this increase in the time constant, the COPD asthmatic lung, as we discussed, will have a time constant of approximately 3 seconds if they have a resistance of 20 and a compliance of 0.15. Okay, because both have worsened because due to air trapping. Okay, so this that means to completely exhale the tidal volume that was inhaled, they will require 3 time constant, which is 9 seconds. So to achieve this complete exhalation throughout the breath or throughout the each breath cycle, a COPD or a asthmatic patient can take less than 7 breaths per minute, which is definitely not physiological, or which is definitely not possible. Okay, now this actually can never be achieved in a patient with COPD or asthma. Now, this reduction in the airway caliber, as we discussed, will cause an increase in the airway resistance, will increase the expiratory time constant, and also there will be added higher compliance, which will be added, which is worse in patients of emphysema, causing dynamic pulmonary inflation, and which will lead to a higher end expiratory lung volume, which is more than the functional residual capacity that is expected, and this will now cause what is known as the intrinsic PEEP or a auto PEEP. So coming to what is intrinsic PEEP or auto PEEP. So it has multiple terminologies. It is also called as occult PEEP, inadvertent PEEP, endogenous PEEP, internal PEEP, or intrinsic PEEP. It has multiple terminologies. So auto PEEP is defined as inadvertent increase in the pressure in the alveoli above the atmospheric pressure. So it is the unintentional PEEP which will occur during mechanical ventilation when a new inspiratory breath begins before the previous expiratory flow has ended or the previous exhalation is complete. So as we can see here, as the alveoli start distending with the retaining of the lung volume after each incomplete exhalation, the alveoli start distending and the PEEP starts, or the end expiratory pressure starts increasing. So there is a linear increase in the alveolar diameter as well as the pressure. But once beyond a point, the alveolar diameter cannot increase further, and then the alveolar pressure starts increasing at a more exponential rate, with the alveolar diameter kind of remaining constant. Okay, so this is what we understand as auto PEEP. Okay, so now how do we measure auto PEEP in a ventilator? So when we have to measure auto PEEP in a ventilator, we have to give a expiratory hold at the in a mode of your ventilator, in a controlled ventilator where the patient is sedated and paralyzed, or not in a spontaneously breathing patient. You have to give an expiratory hold which should be long enough to take into account the different time constants that will exist inside the lung. So when you give an expiratory hold initially, the pressures at the end of expiration will start rising and will eventually plateau. This pressure is now the total PEEP which is there inside the lung. So the total PEEP minus the external PEEP that you have set in your ventilator, that the subtraction product will give you the intrinsic PEEP, or the value of the auto PEEP. So here again, as you can see in this flow time graph, even if you're sure or not, even without doing an expiratory hold, you can find out if there is a air trapping or not. So by seeing the flow time graph. So in this flow time graph, ideally in a normal patient, the exhalation curve should touch the baseline. But in this patient, because there is airway resistance, it does not touch the baseline, and there is some amount of gap which is left. And this trapping or air trapping will cause what is known as the intrinsic PEEP or the auto PEEP. So it is a quick way to determine whether this patient is having auto PEEP or not having a auto PEEP. Now we come to understanding what does this auto PEEP? Is it a real estimate of what is happening in the lungs? So the auto PEEP that we actually measure after giving an expiratory hold is a kind of underestimation of the actual auto PEEP which may exist in the lungs. So to understand this easily, I have shown a figure with 4 alveoli. These 4 alveoli have different time constants, and they have different pressures inside them. Okay, so depending on their degree of obstruction. But this alveoli is completely closed, or what is called as it has a critical closing point, and this alveoli is not communicating with the central airway. Only 3 alveoli are communicating with the central airway, and based on these readings that the ventilator gets, that is the average extrinsic PEEP that the ventilator could the average auto PEEP that the ventilator could calculate was 10 centimeters of water. But if we disregard this alveoli, it is a complete underestimation. Okay, because if we include this alveoli also into our reading, the average PEEP calculated would at least be 15 centimeters of water. So the auto PEEP that we calculate can many a times be an underestimation in an acute exacerbation of asthma or COPD, when most of our alveoli, because of the pathophysiology, are completely cut off from the central airways. Okay. So now this dynamic pulmonary hyperinflation that we saw causes an increase in the end expiratory lung volume, which gives an intrinsic or an auto PEEP, and this causes an increase in the inspiratory effort or the work of breathing. So this inspiratory effort or the work of breathing becomes important in a patient who is spontaneously breathing, because it will have to it would use this work of breathing to overcome the auto PEEP that is there inside the lungs. Okay, and this is what is an important concept when we try to wean these patients of obstructive airway disease. So now to explain you all again. So this is the place where our normal lung inflates. So the amount of work of breathing that is, or the change in the pressure that is required to change a tidal volume is quite less. But in a patient with COPD or asthma, because of the over distended alveoli that are there, or the baseline volume or the pressure of the alveoli is higher, the curve shifts to a more less steeper part of the curve, and that leads to an increase in the work of breathing for the same change in the tidal volume. Okay, and this work of breathing is used not only to overcome the resistance of the airways, but also to, because of the loss of the elastance of the alveoli. So the work of breathing is increased not only during expiration, but also during inspiration. Okay, now this distension that is there in the alveoli that has happened will also cause us hypercapnia. Now, why does this hypercapnia occur? The hypercapnia mainly occurs because of the over distension in the alveoli. The alveolar pressure is much higher than the pulmonary vascular pressure, that is more than the pulmonary arterial and the venous pressure. So we know that we have in a normal lung, we have three zones of West zones, or zones in our prevalence of zones in our lung. But as there is over distension or incomplete expiration in a patient with obstructive airway disease, the alveolar pressure in this lung is more than the pulmonary arterial as well as venous pressure throughout the lung fields, and this will cause an increase in the dead space that is there, and will also cause an increase in the pulmonary vascular resistance. So this increase in the dead space is the reason why these patients have more hypercapnia. Now, having understood all this, let us now again stress that the most important problem that is there, that exists in patients with obstructive airway disease, is nothing but dynamic hyperinflation. Though increased airway resistance is the reason why it starts, or hypercapnia is also a component of it, but it is the dynamic hyperinflation which is the basic, or the baseline pathophysiology in these patients, which we have to overcome by our ventilator settings. Okay, now let us see a case and understand how do we set the ventilator in this patient with COPD or asthma. So this case is a 50-year-old male patient who's an active smoker with an ideal body weight of 70 kg. He's a known asthmatic since childhood, treated with steroids and beta-2 agonists, and he now comes to the ER with complaints of cough, increased expectorations, and worsening dyspnea. The patient daughter tells you that her father is a heavy smoker and he usually is not very regular with his medicines. She also says that his condition has been worsening over the past 2 days with increasing difficulty in breathing, and in the last 2 days he could no longer walk and has been coughing out a lot of brownish sputum. In the ER, when you see him, he is afebrile with tachycardia and showing occasional atrial premature complexes, and the BP is 170 by 95 millimeter of mercury with a tachypnea with a saturation of 88% on room air. When you examine him, he is clinically alert and he appears uncomfortable due to the respiratory distress that he has, and is using accessory muscles of respiration. He has bilateral wheezing on auscultation, and the initial ABG that has been sent shows a PaCO2 of 50 millimeters of mercury with a pH of 7.3 and a PaO2 of 55 millimeters of mercury with a bicarb of 28. So what would you do next in this patient? So what is important is that we have to take a decision whether we have to put a patient on a non-invasive ventilator or on an invasive ventilator. So in COPD patients, because this patient is a smoker and a COPD patients, non-invasive ventilator becomes a grade 1 indication, or COPD becomes a grade 1 indication for the use of non-invasive ventilation. Okay, in this patient, we can use a non-invasive pressure support ventilation with the settings of 12 by 5 and with the FiO2 as titrated. But in COPD patients who are obtunded because of a higher CO2 retention, they can now be also put on the newer modes of ventilation, NIV ventilation, that is a NIV pressure control ventilation, which delivers the set respiratory rate and helps in the CO2 washout or the betterment of the CO2 narcosis. Okay, so the NIV pressure control mode is also used in patients who have higher carbon dioxide retention and are in or obtunded state because of CO2 retention, provided that after putting them on this mode of ventilation, they have a good chest volume expansion and they can still maintain their airway in a drowsy or in a obtunded state and do not have a clear-cut contraindication to use of a NIV. So the decision to put a patient of obstructive airway disease, whether it is COPD or asthma, on a NIV is based purely on a clinical decision rather than on the ABG or the blood gas values. Okay, as I said, COPD is a grade 1 indication to the use of NIV, and invasive ventilation in these patients should be used only when there is a clear-cut contraindication to use of NIV ventilation. So who is the right patient to ventilate? Okay, the decision, as I said, in patients with severe obstructive airway disease is more of a clinical decision. Okay, the patients can be given a trial of non-invasive ventilator if they do not have a clear-cut contraindication, with a careful observation or a care to check for the air improvement in their clinical status and to look for the drop in the PaCO2 levels. But in case at any time the clinical judgment indicates that they need to be ventilated, then they should be ventilated early rather than postponing it. So the main indications why these patients should be ventilated are mainly because of the exhaustion of the patient, because of mental depression of the patient, or because of hemodynamic compromise, or if there is severe hypoxemia. These are main 4 indications why these patients need to be invasively ventilated early and not be given a NIV trial. Of course, if there are other contraindications to NIV, like there is an abdominal pathology with vomiting that is constantly happening, then that is a clear-cut contraindication to NIV, and these patients should not even be given a trial of NIV. Okay. Now, we continue this case. You have put this patient on NIV mode, pressure support mode, as we decided earlier, and an ABG is repeated after an hour. Now, the ABG which is repeated after an hour shows a pH of 7.2 with a PaCO2 now rising to 65 millimeters of mercury, and the PaO2 has dropped to 60 millimeters of mercury. And we remember we had put him on 100% FiO2. Okay, so now the decision is taken to intubate this patient. So this patient is intubated with appropriate anesthetic and sedative agents. As I said, I will not be dwelling into this part of the topic. And we have to now decide what settings do we keep in this patient. Okay. So when we have to ventilate or in a patient with COPD or asthma, there have to be what are our goals that we have to achieve. Okay. So a patient of obstructive airway disease, the main goal, whatever the mode of ventilation that we use, whether it is a NIV mode of ventilation, whether they are assisted modes of ventilation, or whether it is a complete controlled mode of ventilation, the main goal is to reduce or prevent the worsening of dynamic pulmonary hyperinflation, which is the main pathophysiology of this disease. Okay, so in a NIV, again, when we put a NIV, we have to make sure that there is no worsening of dynamic pulmonary hyperinflation, and in fact, there is a reduction in the same. At the same time, the use of NIV has reduced the work of breathing, and of course, there is patient ventilator synchrony with comfort, and to minimize the and we have to make sure that there are minimal leaks. In assisted modes, again, the similar goals are there. In an invasive ventilator, when we ventilate these patients on invasive ventilator, apart from our target to not worsen the dynamic pulmonary hyperinflation, our target should be a slow PaCO2 reduction, and we should not try to increase the minute ventilation at the compromise of worsening the dynamic pulmonary hyperinflation. What is allowed in these patients is what is known as permissive hypercapnia. That means a CO2 value per se does not give us an indication to ventilate or to change our ventilator settings. Higher CO2 is acceptable in these patients to the extent of the pH being as low as 7.15. In fact, it is said that the hypercapnia should be still permissible if the pH is dropping further down, as long as it is not causing any arrhythmias or hemodynamic instability. Okay, now to correct the pH, a slow infusion of bicarbonate can be used in such patients. So the initial settings in these patients, when we decide to intubate this patient, the choice of the endotracheal tube should be the largest internal diameter that can be used in this patient, because using a smaller tube will further worsen the expiratory resistance and by partial blockage, mainly because of the mucosal secretions. The choice of the mode in these patients is basically only one. So to give you all this example I always give, and it's etched in my mind, that once when I was on morning rounds with my boss during my residency, he asked me on the rounds, give me 3 modes that you can use in a patient with obstructive airway disease or in a patient with acute asthma. And of course, with my limited knowledge, I gave him 3 different modes of ventilation. And he told me there are only three modes by which you can ventilate a patient with asthma, and that is volume control mode, volume control mode, and volume control mode. So any patient with acute exacerbation of asthma or COPD, apart from volume control mode, there is no other mode that should be used. The tidal volume should be set as 6 to 8 ml per kg to avoid any further overinflation, because our alveoli are already overinflated. The respiratory rate should be short enough or less, even up to 8 per minute, and at times if the dynamic pulmonary hyperinflation is very high, it can even be as low as 6 per minute, because this will help us prolong the breath time and further shorten the inspiratory time and prolong the expiratory time to allow complete exhalation, or to bring it close to the 3 times constants that we want for our diseased alveoli or our over distended alveoli. We should avoid targeting PaCO2 to set our respiratory rate or our tidal volume. The I ratio should be set anywhere between 1:3 to 1:5. There is very poor rationale to set a I ratio more than 1:5. The inspiratory flow should be 50 to 60 liters per minute, which will further help to shorten the inspiratory time and to give us time for exhalation to be as close as the time constants that is there. The PEEP initially in patients who are intubated and kept sedated and paralyzed should ideally be kept 0 or as low as possible, because there is no rationale to give an external PEEP in the patient who has just been intubated, who has a very high auto PEEP and who is completely sedated and paralyzed. So when to use extrinsic PEEP, I will be subsequently telling you all in the coming slides. The FiO2 should be targeted to maintain a saturation of 88 to 90% only, and preferably a heated humidifier should be used, and the HME should be avoided to reduce the anatomical dead space that is there. So before we continue further, I would just quickly show you all the simulator, how we do the settings. Okay. So this similar patient I have set on the ventilator already, who's a patient of COPD with a 70 kg of ideal body weight with a higher resistance, and now he has been intubated, and these are the settings. We have put him on the controlled mode of ventilation. Okay, and the tidal volume, as I said, we have set it to, and these are the graphs that are achieved. So this is the pressure time graph, and this is the flow time graph. This is the graph where I was saying that there would be incomplete expiration, and as you can see, it is clearly visible that this expiratory curve or the expiratory wave does not touch the baseline, which is an indicator of air trapping. The similar thing can be seen in a flow volume loop that is there. So in this flow volume loop, as you can see again during expiration, ideally this expiratory curve should touch the 0 or the point where the vertical and the horizontal line intersect, but it is at a little distance. Do not get confused with another flow volume loops that you all usually see, where this expiratory curve ends a little away from 0 on the horizontal line. When that ends here away from on the horizontal line, but more than 0 or with some volume left, so that indicates a leak. Whereas if it ends on the vertical line away from the 0, it indicates bronchospasm or incomplete expiration. So leak and bronchospasm are two different things. Okay, so these are the settings that we have set in this patient, and we are allowing complete expiration. So I will just show you all. So that we have set a respiratory rate of 10, and we have set a tidal volume of 420, which is 6 ml per kg as per the 70 kg ideal body weight that is has because of his height. And in this patient, luckily, we do not have a very high peak. But in a patient with COPD or asthma, when you ventilate after when you intubate and ventilate, they may have a very high peak values, even going up to 70 to 80 centimeters of water. So usually when we put these patients on ventilator, because our pressure limits on the ventilator are usually set at 40 to 45, the tidal volume that we have set usually does not get delivered. And as a reflex, we have a habit of shifting these patients to a pressure control mode, assuming that they are getting ventilated better on a pressure control mode. But it is very dangerous to put them on the pressure control mode because of two reasons. I will come to those reasons. Okay, so it is safer to ventilate on the volume control mode. All you have to do is increase your alarm limits of the peak pressure to allow your set tidal volume to be delivered. You can go down further on the set tidal volume. And in this patient, because I am not completely taking care of the dynamic hyperinflation that is there, I would like to go down on the respiratory rate to 8 and see if I am able to completely expiration. So why should the pressure control mode be avoided in these patients? Basically, there are two reasons for it. One is a pressure control mode does not allow us to give the set tidal volume that is there. And when a patient with COPD has increased pressures in the lungs, okay, if the pressures worsen or if the bronchospasm worsens, then it may actually further compromise on the tidal volume and may cause a rise in the CO2 levels or in the dynamic hyperinflation that is there. And the other risk that exists is because you have to set a very high pressure limit to deliver the required tidal volume. And if you continue giving bronchodilators and steroids to this patient, and when the bronchospasm gets relieved, this high pressure gets delivered to the alveoli directly and may even cause rupture of the alveoli and sudden tension pneumothorax and may be a cause of arrest in these patients. Okay, so there are only three modes, as I said, or my boss says, to ventilate a patient with obstructive airways disease. That is volume control, and volume control. And please do not think of any other mode when you are planning to ventilate these patients. Okay, so this is the initial settings, as I said, and we go back again to our slides. Okay. So now this case is continued. So when you have intubated this patient, you have planned to put him on a certain settings that is there. But immediately after intubation, you notice when you connect him to the ventilator, you notice that his patient has sudden severe hypotension. And when you have started to initiate positive pressure ventilation, and he is suddenly tachycardic with a pulse rate of 135, which is sinus. His BP is dropping to 82 by 44 millimeters of mercury with a saturation of 68%. And your ventilator is showing a high peak pressure alarm of 70 centimeters of water and a plateau pressure of 40 centimeters of water. Okay. The plateau pressure has also increased. And as you are trying to re-examine this patient, you find out there are hardly any breath sounds which are heard on both lung fields, and high airway pressures are required to achieve a very small tidal volume. The carotid pulse, which was initially palpable, has started to disappear. And what do you think would have happened? So in these patients, when you who have a very high air trapping or very high auto PEEP, and you intubate and ventilate them, they suddenly have increased air trapping, or the intrathoracic pressure suddenly rises, and that reduces the preload and can be a cause of arrest immediately after intubating or putting them on the positive pressure ventilation. So the immediate step that should be taken is to disconnect the ventilator and to allow the release of the trapped air that is there inside, and then reconnect it. Another reason why they will have hypotension is also because they are hypovolemic. They may be hypovolemic, and with the loss of sympathetic drive, and the increase in the intrathoracic pressure, it further worsens the venous return. So they should also be adequately hydrated before planning to intubate these patients. So as we all discussed, we have kept a respiratory rate of 8, tidal volume of 420, 0 PEEP, FiO2 of 1, and the IE ratio of 1:4, and a flow settings of 70 liters per minute to allow adequate expiratory time for the complete exhalation of the lung volume. So this is just, I'm trying to give a case scenario. This is not related to the same settings. So in this patient, we kept a flow of 60 and an inspiratory time of 0.8 seconds with the expiratory time of 2.2 seconds and a tidal volume of 400 ml. And here the inspiratory PEEP was 14 with a PEEP peak of 33 and PEEP flat of 20. Okay, and a respiratory rate we had said at 20. What will you do as a next step? I'm so sorry. So, so what do you think is the reason that the intrinsic PEEP is so high? So to avoid the intrinsic PEEP to rise further, what we should do is we should come down on the respiratory rate. The tidal volume is ideal, but we should decrease the respiratory rate as low as possible to allow complete exhalation or to allow the expiratory graph to touch the baseline. So what is the significance of peak pressures and plateau pressures in a patient of obstructive airway disease on invasive ventilation? So the peak pressures may be very high and there cannot be any limit to this. And the high peak pressures is not of any concern in these patients because this arises mainly from the increased airway resistance or the high inspiratory flow rate that we set to allow us a better expiratory time. So this is the reason, and this peak pressure does not reach the alveoli and is not harmful to the lungs. What is important is the PEEP plateau pressure, which signifies dynamic hyperinflation, and our target should be to keep this plateau pressure less than 30 centimeters of water to avoid any barotrauma that is there. So this is the reason that So in the previous settings, in case if the plateau pressure is 40 centimeters of water, we should further reduce our respiratory rate and tidal volume to achieve the least minute ventilation, to avoid any air trapping or to release the dynamic hyperinflation that is there. Okay, this with these less settings, we have to agree to the concept of permissive hypercapnia. And despite giving bicarb and everything, if the CO2 is still very high or at dangerous levels, there is now the option available for extracorporeal carbon dioxide removal. So what is the role of extrinsic PEEP? Okay, now this is one thing which we need to understand very carefully, or very carefully, or with I mean very carefully. And when do we use our extrinsic PEEP in these patients with obstructive airway disease exacerbations? Okay, so when you see this two graphs or two figures that are there, so here we are trying to show one alveoli. Now this alveoli has air trapping inside, but in the airway, if you can see, there is a complete obstruction that is there. This is similar to what I told you when I showed you all the figure of 4 alveoli, wherein the one alveoli was completely closed. So this alveoli this airway is completely closed, mainly because it has significant changes in the bronchial van, and also because of the loss of traction that comes to keep these airways open. So this leads to a equal pressure point or a critical closing point in the airway, which causes a complete closure. So at this point, since this alveoli or this airway is completely closed, this alveoli has trapped air inside, and which may be one reason why the P plateau is high, despite the expiratory PEEP may not be showing you as much, because the expiratory PEEP, as I told you, or rather the intrinsic PEEP, that when we measure, the intrinsic PEEP that we measure may not be very high, despite the P plateau being high because of the trapped air. The reason being this, many such alveoli are not communicating to the central airway, and therefore the auto PEEP that we have measured is actually an underestimation of the real auto PEEP that exists. So we have to be very aware of this point. And as we give more medications, this obstruction may get relieved in certain alveoli, but in many, it may not get relieved, and we may want to relieve it earlier. And at this point is when we decide to give a extrinsic PEEP to open up this airway, so that this airway starts now emptying with the next breath cycle that is there. So this helps us to homogenize the alveoli. That means all the alveoli, this helps us to allow all the alveoli in the lung to communicate with the central airway. So this is very important just before we are planning to wean these patients. So when we intubate a patient, if I have set, for example, if I have planned to intubate this patient, and I find that the auto PEEP is 8, and after giving medications, my bronchospasm starts decreasing, and more alveoli are now getting communicated with the central airway, because these airways have now started opening up. So we may actually find the auto PEEP increasing for certain amount of time. At the same time, if I find that the P plateau pressure is very high, but the auto PEEP that I calculated is not that significantly high, is the point when I need to understand that there are many more alveoli which are still closed or completely cut off from the central airway, and that is the point when I should think of giving an extrinsic PEEP, especially before when I'm trying to wean such patients. Because if I try to wean them without opening up these alveoli, or because without opening up these airways, or without causing exhalation of this trapped air, there would be a clear-cut failure of weaning that would be there. So how do we decide what auto PEEP to set? So to understand this issue of external PEEP that will face the intrinsic PEEP, now there is a quite controversy to understand this, because many people also argue with the fact that when you give an auto PEEP in a patient who already has a significant intrinsic PEEP, that you may actually worsen the intrinsic PEEP. But this is not a fact, because if you imagine a waterfall wherein this is the alveolar pressure, or the pressure which is existing in this airway, in this alveoli, whose airway is completely cut off from the central airway, that is the trachea, and the critical pressure where the airway has closed, at the pressure at which the airway has closed, is the point at which this waterfall is beginning. So now I have to give a extrinsic PEEP which remains below this critical pressure. I have to make sure my auto PEEP does not cross this critical pressure. Now the question will be, how will I calculate what is the critical pressure? So clinically at the bedside, we have no way to calculate what will be the critical pressure inside the lung above which I do not have to give an auto PEEP. So the basic formula that we use is we should not exceed our auto PEEP more than 60% of what we have measured. So if I have measured an extrinsic PEEP or auto PEEP of 12, I should not exceed my set PEEP more than 8 centimeters of water. So if my auto PEEP is 12, I will not exceed the extrinsic PEEP that I apply more than 8 centimeters of water. And as you're applying this extrinsic PEEP, so 8 is my upper limit, but as I'm applying this extrinsic PEEP, I will be slowly going up from a level of 4 and gradually increasing it by 1 to 2 centimeters of water. And at the same time, I will be watching the P plateau pressure. If my P plateau pressure starts rising when I'm applying the extrinsic PEEP, that means my extrinsic PEEP has now crossed the critical pressure point. Okay, so I have to keep the extrinsic PEEP 60%, and at the same time, when I'm calibrating or this extrinsic PEEP that I'm applying, I have to keep a watch for the P plateau pressure and make sure it does not increase as I slowly keep going up on the application of the extrinsic PEEP. Okay. So now I continue this case. The patient is on the ICU. He is maintaining well, and we give him nebulization, steroids, and whatever treatment that we have decided. Suddenly on the second day, he develops a hypotension, which quickly progresses to a pulseless electrical activity, and the patient arrests. The BP is not recordable, and there is no perceptible pulse, and the SpO2 trace is not clear. Ventilator shows a sudden rise in the P peak with difficult to ventilate, and on auscultation there is no air entry, only on the left side. So here this patient has developed a tension pneumothorax, and which is the cause of the arrest or the PEA rhythm that is there. So doing a quick needle thoracostomy and inserting an ICD would be life-saving. So being aware of this point that these patients are at high risk of high risk of barotrauma, and rupture of the alveoli causing tension pneumothorax is another important point. And to be aware of this or to troubleshoot this, what is important is that we should set our alarms and monitoring targets very clear in these patients. So especially important is the peak pressure alarm. So the peak pressure alarm should be set close to 10% of the P peak value that is there. So that means when I put the patient on the ventilator, and if my P peak is 70 centimeters of water, my P peak alarm should be up to 77 to maximum 80 centimeters of water, and not more than that. If because of repeated alarming, my nurse or anybody of my doctors just goes and makes that P peak pressure alarm to more than 120, the patient may actually rupture and go into a sudden arrest without even be realizing what is the cause of the arrest. Okay, and we have to make sure that at all times we keep the P plateau pressures less than 30 centimeters of water, and to achieve an intrinsic PEEP or an auto PEEP as low as possible, preferably to less than 10 centimeters of water as early as possible. So now this case continues, and the patient starts improving over the next 4 days, and now we decide to wean this patient. So to wean these patients, what are the settings that we keep? Okay, so to understand this again, we have to understand here comes the role of again applying the extrinsic PEEP. So when we are weaning these patients, we start putting them on the assist control modes. So when we put them on the assist modes, the patient starts making an effort to start breathing. So now when it starts to breathe, there is an intrinsic PEEP that the patient has to overcome before it gives an effective trigger to the ventilator to deliver the breath. Now, when we give an extrinsic PEEP to this patient, the effort or that it needs, or the pressure that it needs to generate, is comparatively lesser, or the work of breathing that is to be done to overcome this pressure is comparatively lesser, and it is easier to achieve the effective trigger for generating the next for initiating the inspiration. So here is the role of again the extrinsic PEEP. When we are trying to wean these patients, or when we have planned to stop the sedation in this patient, we should start giving them an extrinsic PEEP, which again should not be more than 60% of the total intrinsic PEEP or the auto PEEP that we have measured. Next important point that we need to keep in mind when we wean these patients is the level of assistance that we provide. So when we provide we put them on the pressure support mode, we should make sure that the pressure support that we give is not high enough so that they generate a higher tidal volume, because the higher tidal volume that they generate, they will require longer inspiratory times, which will further compromise on our expiratory time and may again initiate the cycle of dynamic hyperinflation and the pathophysiology may worsen. So our target is to set the pressure support only as much so that the so that it generates a tidal volume of 6 to 8 ml per kg only. So we should avoid over assistance. Other important point is to set the expiratory trigger sensitivity. So expiratory trigger sensitivity is the trigger that we set for the ventilator to know when it has to cycle from inspiration to expiration. So in a normal patient, we put an expiratory trigger sensitivity of almost 25%. Okay, that means when the inspiratory flow rates drop to 25% of the peak inspiratory flow rates is when the cycling happens or the expiratory valve opens. But in patients with COPD, because we want a shorter inspiratory time for them, we set this expiratory trigger sensitivity to 40 to 50% of 40% average. But in some COPD, bad COPD patients, we may even have to set it at 50% of the peak inspiratory flow rate. So we have to set a higher expiratory trigger sensitivity. Okay, so let's again see this in on our simulator. Okay, so we have now planned to wean this patient, and we are going to change the mode to spontaneous mode. Okay, that is the pressure support mode. And of course, the trigger is set. As I said, we will go up on our expiratory trigger sensitivity to at least 40% or maybe higher as required by the resistance that is there. My pressure support value has to be low enough to allow a tidal volume of only 6 to 8 ml per kg. Okay, so I may start at 5, 6, and I have to give an expiratory PEEP, which is 60% of the 60% of the intrinsic PEEP that was there. And again, my FiO2 should be just enough to allow a saturation of 88 to 90%. Okay, so I confirm this settings and I put this patient on the weaning mode or the expiratory mode that is there. Okay, but my CO2 has risen, so this is not the ideal time to wean, but I'm still showing you all the settings because we gave him a very low tidal volume all this while. The CO2 is very high and not the ideal time to wean anyways. So again, 3 important points. One important point is to have a expiratory trigger sensitivity, which is kept higher, that is about 40 to 50%. Second, we have to give a pressure support decent enough to allow a tidal volume of 6 to 8 ml per kg only and not higher. And the third point is that we give them an extrinsic PEEP up to 60% of the intrinsic PEEP to help them overcome, to help them decrease their work of breathing to generate an effective trigger. Okay. Coming back again to our slides. So once you have decided to put them on a weaning mode, and if they successfully wean, now comes the extubation. So how do we extubate these tricky patients of asthma and COPD? So in asthmatic patients, they have a hyperreactive airway disease. And here is where, when we stop the sedation of these asthmatic patients, their airways again start hyperreacting and they may be going into an acute bronchospasm, failing your weaning trial. So here comes the role of sedation, wherein we give them a sedation which is easily weanable. So like, if I'm planning to extubate a asthmatic patient tomorrow or to wean a asthmatic patient tomorrow, then I would put him on an overnight propofol infusion, and which when stopped will easily wear off. So, and I can extubate him before the patient is completely awake and will reduce the hyperreactivity of the airway or allow early extubation in these patients. Nowadays, apart from propofol, even dexmed or dexmedetomidine is used in these patients. But still, my favorite choice is still propofol if the hemodynamics permit me. And if the hemodynamics do not permit me, then probably it is not the right time to wean them. Okay. And in COPD, there comes the role of NIV when we try to extubate these patients. So in COPD, the non-invasive, we try to extubate these patients on to non-invasive ventilator rather than to oxygen or on room air. The reason being, these patients have a chronic airway obstruction or a chronic air trapping, which puts their respiratory muscles at a compromised position, especially the diaphragm, which is lower down, and it puts them at a compromised position to generate adequate tidal volumes with more muscle fatigue and they have a lot of muscle wasting. And this is the reason why they may require a prolonged pressure support that is there. And the easier way off is that when they are fully awake and they have tolerated the pressure support mode, give them a short key trial of 30 minutes and extubate them to NIV early, or they become difficult to wean and may land up on a tracheostomy. So to conclude, we should, in a patient with obstructive airway disease, when we are trying to ventilate them, we should make every effort to minimize their dynamic hyperinflation, which is the basis of all the pathophysiology in these patients, which will help to reduce the work of breathing and to minimize the wasted effort. We should give them a shorter inspiratory time, a longer expiratory time, a least assistance levels, and the cycling threshold, higher cycling threshold, and the PEEP when we are trying to wean them, to allow opening of the critically closed airways, and also to decrease the work of breathing while for triggering. We should monitor them for pulmonary hyperinflation, their efforts, and their rate. And finally, a simple small slide on congestive heart failure. When we, for the mechanical ventilation of congestive heart failure, the only role, that the most important role that is played is by the PEEP. The PEEP here is mainly has two purposes. One is to decrease, of course, decrease the pulmonary edema, but also to reduce the work of breathing by not only reducing the pulmonary edema and the work of breathing, but it also helps to improve the hemodynamics by decreasing the preload and afterload, and also to help the heart pump a little better. So there is preferential use of PEEP in these patients for multi-purpose rule, and that is the giving the higher PEEP for these patients. So the tidal volume again is the same. We keep 8 ml per kg, 6 to 8 ml per kg to titrate FiO2 to achieve a saturation of 90 to 94%. And again, the plateau pressures should be kept less than 30 centimeters of water. Respiratory rate again to set a CO2 of 35 to 45 and a normal pH of 7.35 to 45. And we should again look at weaning them off early. And again, in these patients of congestive heart failure, NIV, congestive heart failure is a grade 1 indication for using NIV, because most of these conditions are very rapidly reversible by use of right medications. Thank you so much. I'm open to questions.